So maybe while you're waiting for it's Rod Pearce here again, I'll get back to the measles and just thinking about the fact that when someone's pregnant, we test for measles and a whole lot of other vaccines. Once upon a time, we used to give HPV vaccines just to women, not to men. So do you think we should be testing men when their partners or someone they're associated with gets pregnant to make sure they haven't got measles because we don't want to spread it? And is that a good way of actually checking and maybe improving our vaccine coverage for measles?
Thanks for the question. I mean, please correct me if I'm wrong from the audience, but I don't actually think measles is routine or antenatal screening. It's rubella that we screen for. I think the key challenge we have in this population is that MMR is a live vaccine. We don't have an inactivated vaccine, therefore we would not usually give it in pregnancy. I mean, I think it's that pre-conception counselling. If people are coming to you about wanting to start planning, that's a really great time to do it. And I think it makes sense to kind of do it for both the woman and her partner. I think the challenge is recording of vaccines is patchy, as you'd all be aware. You know, the AIR only expanded to adult vaccinations, I think, in 2016, and it's only been compulsory to record adult vaccinations mandatory or given under the NIP since about 2020, and so we often don't have vaccination records for these people. So often it's just really giving them the vaccine if they don't have the vaccine records, but we wouldn't do that during pregnancy. Does that answer the question?
We're getting nods from Andrew online as well.
So, yeah. I'm not sure about checking, serology. I think if somebody under the age of 60 hasn't got documented evidence they've had 2 vaccines, I'd give it. I think that, and I'm sure I've read that somewhere, that's the advice is not to rely on serology. It's on the history or the lack of a history. So give it, and clearly not when pregnant.
Yeah, absolutely. I think where we use serology is really in people who we can't give the vaccine to, or where there's, where they're perhaps older and they had a history of disease, and we wanted to confirm that.
Yep.
Thanks. We just got another measles-related question from our online audience. With the current measles sort of outbreak, there's comments that transmission is becoming endemic. Could you comment on this, and also how best to address? So it might be just worth adding to those strategic comments there, but particularly around endemicity, whether you think we're really moving into that phase.
Do you want me to take that first, Andrew?
Yeah. Sarah, you can go first.
Yeah, sure. So there have definitely been documented cases where there have cases of measles where they have not been able to trace them back to a traveller source. Now, one of the challenges of measles, I think, is that it's so highly infectious that you could walk into a supermarket or into a, kind of large shopping centre where a measles case has been and potentially acquire measles that way. So I think sometimes it's hard to do the contact tracing, but I think there is definitely risk that endemic transmission could become established because of the low vaccination rates. So I think the public health response to every measles case is still highly important, and I think we really need to try and improve vaccination rates. Travel is a great opportunity to have that discussion with people about updating their vaccines for other things, because I think they're generally primed to get some needles in their arms. But I think we need to be doing that more broadly and seeing any prevention opportunity with our younger people as an opportunity to go, actually, let's get you up to date with measles. Because as we saw in the data that Andrew showed, that is actually the age group where we're seeing a lot of cases, as well as the young children. But unfortunately, the young children is often people who are either too young to receive vaccination, and they're often secondary contacts of a case rather than the traveller themselves. So someone brings measles back and then spreads inside the household.
I had a very astute travel doctor who I went to see recently, and you'll be pleased to hear one of the first vaccines that I was going to Africa, so I was expecting all these exotic vaccines, and the first one he said was MMR.
I'm so happy to hear that. And if I can, you go first, Andrew.
I was going to say, yes, MMR closely followed by flu, just following on from what you were saying, Sarah, about being the most important vaccine preventable disease in travellers. So I think that's not relevant to this question, very important as well. But in regard to endemicity, it only takes one imported case of measles from overseas for elimination to become endemic. And I think it's the public health response which I think has been done very well. Well, I don't know. I mean, it seems to have contained it and has raised awareness. And as I said in my session, the secondary cases, what was it? So did I say sort of doing about 16 or 18 per case? And of course you're infectious for 4 days or so before the rash appears, so there could be a lot of measles virus around in the community before you even know someone's got it. So it's a very high risk situation. I just think it's just awareness and monitoring and public health. But I don't know whether we'd say that Australia is now back to endemic measles. I don't know what the criteria for that would be, but I don't think that's quite the case. Sarah, what do you think?
No, I don't think we've gotten to that point yet, but I think there is definitely a risk, and so we need to be alert to that. I think the other good news story for measles is that you can use the vaccine for post-exposure prophylaxis. So if you catch someone early after they've been exposed to measles, ideally within the first 72 hours after exposure, and vaccinate them, because measles has a longer incubation period, generally 10 to 14 days, you can actually prevent them from getting measles. So vaccination is not just important pre-exposure, but also in the post-exposure place.
Now, we'll give some chance to some questions on your other diseases shortly, but there's one here in our online comments which I think is rather pertinent to, what can we do about measles? It says, in the context of increasing current measles cases, what could be done to get the secretary approval for nurse immunisers to give MMR to the 6 to 11-month-old children travelling overseas during nurse-led immunisation sessions? For example, it's saying here that it's funded for the 6 to 11-year-olds in Victoria, but nurse immunisers can't give it without a doctor's order. Who's got influence with the secretary to get that changed?
Great question.
Yeah, well, there's some practical opportunities then, obviously, to get the ability to be able to vaccinate the people who are at risk, etc. And as we've spoken about, the role of the nurse immuniser and making that really practical and easy to implement is great.
It's another barrier to vaccination, and that needs to be removed. Yes. And I don't know the means to do that, but I recognise the frustration that the questioner has in that they can provide that service yet have been blocked. So to their disadvantage and to the patient's disadvantage. It's,
The other population I just wanted to mention, and it's a bit of a pet topic for me, but people who are about to be immunocompromised or about to be immunosuppressed. So we're seeing widespread use of an increasing range of immunosuppressive agents for an increasing range of conditions, including biologics. And most providers who are doing a lot of this will do pre-immunosuppression screening, and I think part of that pre-immunosuppression screening should include looking at people's vaccination records and updating them with MMR, because once you start them on the immunosuppressive therapy, it's hard to get them off and you can't give the live vaccines. So if anyone's doing that, please, I would urge you to check their MMR vaccination status and get them up to date.
I'm just checking to see if there's anybody else has got any last questions. So please do pop up if you want to be the last voice. But I have one question that I do want to bring in, just to move on from measles. You spoke about quite a range, and often in the case of travellers. But we do know that with climate change, things are altering for Australia, and the situation we've had with JE over the last couple of years has been a case to demonstrate that. How long do you think we have, or do you think it's a potential, or are we at risk for some of the others you spoke about, chikungunya and dengue, TBE? Yeah,
so really great question. I guess it comes down to what are the mosquito vectors that spread these diseases, and I didn't really cover that, but they are different. So for Japanese encephalitis, it's Culex species mosquitoes, mainly Culex trientericus, but a range of other species. But we have those mosquitoes in a wide area in Australia, and so that's why JE has been able to come so far south. JE kind of came into Australia from, we think, Indonesia or Papua New Guinea, and it's brought by water birds migrating south, and the more you have rain, the more you have floods, the more the water birds come into the areas, and then they can transmit the virus to the mosquitoes and onto humans. Humans are a dead-end host for JE. But I think in terms of the other diseases, we do have Aedes species mosquitoes, so they're the ones that spread dengue, chikungunya, yellow fever, in northern Queensland mainly. And we've had a very successful public health program rolled out, which is a Wolbachia infected mosquito program. I don't know if people in the room are aware of that, but essentially what they do is they use a bacteria that's actually from a fruit fly, put it into the mosquitoes, and it makes them less capable of transmitting infections, particularly dengue. But actually there are some studies that show that it works for other diseases too. So that's been a great public health news story for northern Queensland, where we have seen almost zero onward transmission of dengue in the areas where they've had Wolbachia mosquito releases. And that would protect as well against chikungunya outbreaks. But I mean, as climate change increases, mosquito populations are likely to increase as well, so there is risk.
Thank you for answering that for me. Sorry, we're going to go to, I think, our last question. You did take me up on the offer there, but to have the last question, so that's excellent. Please go ahead.
I used to work in the Women's and Children's in the immunisation clinic, and we used to do all the oncology children, so post-chemotherapy, post-stem cell transplant, so revaccination program. And I just wonder if, across Australia, if they have something for the older population that have had post-chemotherapy, post-stem cell transplant services?
Really great question. So I can only really speak for my hospital, the Alfred, but we do have a post-bone marrow transplant revaccination program. I know that there's also one at Peter Mac, which is the big kind of cancer hospital in Melbourne as well. So there's definitely places where it is happening. I'm not sure that it's systematic, but yes, certainly that is happening.
Yeah, okay, thank you.
For adults.
All right, well, my alarm went off very timely during that last question. Sarah, you and I might just sit here, just make it quick, but we're going to invite now Rod to come back up to do the closing of our day, because I'm sure there's some people who've got some flights, etc., to get to. So I'm going to pass back to you, Rod.
Thank you.